Well, let me invite our final panel of work from the work group to come up. This is the co-leads of the Research, Data, and Metrics Working Group, which is led by Dr. Carlos Blanco, Director of the Division of Epidemiology Services and Prevention Research at the National Institute on Drug Abuse. And to my immediate right is Dr. Kelly Clark, President of the American Society of Addiction Medicine. Following their presentation, which I mentioned will be the last presentation, we have Dr. Itay Danovich, the Chairman of the Department of Psychiatry and Behavioral Neuroscience at Cedars-Sinai Medical Center, and Dr. Julie Donahue, Professor and Vice Chair of Research in the Department of Health Policy and Management in the University of Pittsburgh Graduate School of Public Health. Please begin.
Well, thank you. And thank you all for still being here with us today as we talk about Research, Data, and Metrics Working Group. And I know this is not the most exciting thing for many of you in the audience, but in some ways this becomes, I would say to Dr. Alexander's point, really a core piece of work of this collaborative. So, as with all of the other work groups, we are composed of folks coming from a wide variety of stakeholder groups. And in fact, this particular work group spans the other work groups. So this work group is made up of individuals who are part of one of the other work groups. Okay? So our mission really is to collect and assess best practices and needs in the areas of research, data, and metrics that are relevant to these four focus areas and the overall goals of the Action Collaborative. So we are here to support and help move forward the goals of each of the other groups. And so as we engage in our activities, as these working groups that you've already heard from are engaging in their work, they'll identify what information it is, data, metrics, best practices, etc., that they need to carry out their objective or that task. They'll determine if they can easily access that information, and if so, where is it? And if it's not available, then they will flag that also as a gap. So when the working group is unable to locate those data or metrics, that running tally of gaps is something that this research, data, and metric group will hold. So basically, we are the internal library for information so that each working group does not end up working in a silo, that it becomes really a cross-functional kind of process. And as the gaps become identified, if it's something that can be done during the time of the collaborative, then we can use resources of the collaborative to find some of the information. And if not, one of the things that we will do in the end is to really triage all of the gaps of research that are out there, and working with the steering committee, come forth with what becomes the research agenda for the country across all of these different areas. But to get back to something mentioned earlier, we also need to look at what are our goals. And we recognize that a webinar is not an outcome and a document is not a goal. Those are simply distribution methods of recommendations and information, but just providing information is not the point of an action collaborative. So for each of the topics that you saw earlier, this group asks the question of folks doing this work too, what is the goal you are trying to achieve? What is the actual outcome in the community that you are trying to get to see happen? How will you measure that? What is the action you want taken around this issue? Who is the group or organization or groups of organizations that should be doing that? And then who's doing some oversight of that to see if it's done? And measuring the outcome of the collaborative means measuring, have the recommendations been taken up, how much have they been taken up, and how much impact have they had? It's sort of a meta research, data, and metrics that continues beyond even the course of providing those deliverables. And I would, again, thank Dr. Alexander for pointing out some of these very, very key and important issues for us. So because of the nature of the work that we are doing, our primary work happens later during the course of the collaborative, clearly. We are here to support the other work groups as they're doing their work, and also to see if there are issues that are around the larger issues of mission and goals that are not being addressed by the products and processes and items that each of the work groups is working on, and to kind of keep those in mind too. So our primary work here has yet to really begin in the primary work, but it's that overlie of construct that is the work of this particular group. So Carlos, do you have anything to add to that?
Well, I should not disagree with my co-chair, but I will. I think this is the most exciting group of all. No, and I mean that's why I agreed to be part of the group. I try not to agree to be on to participate on things that I think are boring or unimportant. I mean, sometimes I have to do it because if my boss tells me to do it, like everybody else, you have to do it. But in this case, I was very enthusiastic, and the reason why I think this is the most important group is because, as Peter Drucker said, you cannot change what you cannot, or you cannot manage what you cannot measure. And so I think it's crucial for us to really measure the outcomes. And my hope, and I think the hope of most of us in the collaborative, is that the collaborative and its product is going to survive the short life, the 4 or 2 years that will be on the collaborative. And so creating some metrics of what we want to create are going to be crucial to really manage the crisis. As the Admiral was saying this morning, this crisis is not going to be, this is more like cancer than Ebola. This is not going to be solved in 1 year or 2 years. This is going to take many years, many people, and many billions of dollars really to solve it. No? And so creating the metrics and the structures that we need, I think, is crucial. And also to the extent that we want, following the spirit of the academies, to create a learning healthcare system to manage this issue, we need the data so that we can engage organizations, measure the metrics in those organizations, and then feed that back to the research organizations to really lead the research and continue and have this sort of continuous process of improvement. So that's why, again, I think I'm very inspired by the collaborative, but I'm very inspired by a group, and certainly by my wonderful co-chair. And with that, I will pass it to Dr. Danovich.
Great. Thank you. I share the sense of inspiration, and I'm humbled to be here participating in this capacity. My name is Itai Danovich. I'm the chair of the Department of Psychiatry at Cedars-Sinai. And my involvement with this space has been really at 3 levels. At the policy level, serving on a commission, state commission in California, overseeing really public mental health, including this and several other related issues, many other related issues. With my professional associations, including particularly ASAM. And then most importantly to me, in my day-to-day job, I both see patients who suffer from substance use disorders. I'm an addiction psychiatrist. And I also struggle to implement the types of things that we're talking about within a large, relatively well-resourced health system, and still encounter many, many challenges. So the overarching theme of my response is first an affirmation for the wonderful work that this collaborative has set out to do, and I would give emphasis to Kelly's points about what I would take as like kind of implementation science. And ensuring that we have an implementation measure around each of the working groups' work, and that we are sensitive to the implementation challenges on the field and on the ground. And I tried to orient as I thought about reacting to the work that we're doing, that was the orientation I used. So at the patient level, the question that I've asked myself reviewing all the materials is, how do we empower patients to be informed consumers of appropriate medical care? How do we stimulate their skepticism around new opioid prescriptions? How do we get somebody coming in for an analgesic to respond to that the way many of my patients respond to me when I'm offering them a psychotropic? No way, until we discuss it and we determine that it's appropriate. How do we engage patients that have a substance use disorder or opioid use disorder to expect and demand high-quality addiction treatment? I think that this has been elevated through the elevation of patient-reported outcomes, but I think we need to think of patient-reported outcomes as not just collecting data that patients value, but collecting data that patients value so that patients can get involved in the care pathways and care systems. And we need to be thinking in the language of shared decision-making, and other frameworks that really think about how do we engage and empower our patients as consumers so that they hold ourselves and our programs and our colleagues accountable. I think publishing quality metrics, even if they're imperfect, is a huge, huge part of that. At the provider level, I find taking care of patients with opioid use disorder incredibly rewarding and meaningful, and I find that when my colleagues start to do it, they do too, even if they're not trained in addiction, yet the majority of them carry misguided notions that they can't make a difference. Or as one put it in a pithy way to me, it takes 1 minute to write a prescription for an opioid and 20 minutes to say no, and there's just not enough time. So one of our huge implementation challenges in our busy, intense, chaotic healthcare system is the erosion of time. So many different factors have intruded on the time clinicians have with patients, and this is a condition that festers and then grows where there's the absence of human connection and time to hold hands and to really address problems. So I think we need to look at restructuring service delivery models to enable clinicians to do what they're good at doing, to have more time. And we need to do it through using technology not to add additional burdens to our clinicians, but to reducing burdens. We have a lot of opportunity around data harmonization. I always, as I'm sure many of you, marvel at how easy it is to get data harmonized banking information or Amazon information, and how many clicks it takes to get cures information or prescribing information. That's something that we have to address. And the measures around this, at least at the provider level, providers doing the right thing, are measures of underutilization. We can measure underutilization, and we know, as we know from prevention, that increasing utilization of preventive interventions is going to make a difference. At the program level, we use the language of learning health systems. I think that's just an imperative. This is not a crisis that's going to be solved top down. It needs to be solved both top down and bottom up. And one of the things that I've observed as both a clinician and a researcher is the regulatory framework and complexity of methodologies for conducting research have gotten more and more sophisticated. There's been this division in the field between clinicians and researchers. And if you do quality improvement, you can go ahead and measure what you want. But if you say you're doing research, you are subject to many regulatory factors that are well-intentioned and important, but that become their own obstacles. So how do we reduce the regulatory burden of doing local research, particularly on low-risk, high-benefit, observational-type research? How do we reduce the inefficiency that happens when you send something to the IRB? How do we develop methodologies in the performance improvement or quality assessment space that are useful to clinicians and programs on the ground that want to adopt good practices? They want to use empirical methods, but they're not quite up to the par of being able to do formal research. This is also an area where we struggle with fragmentation. The service delivery model is fragmented. There are many areas where the resources that are needed to have an impact are available, but they're just not tightly coordinated. So how do we overcome physical fragmentation with technological coordination? And again, the harmonization of data is a huge factor there. And then the final comment that I'll make is around the policy and social space. We know that, certainly overdose deaths have been characterized, I think, quite poignantly as deaths of despair. And there are many indications that there's overlap between what we call overdoses and what we call suicides. How do we address the alienation, the social disconnection and disaffection that underlies this? There are so many on the policy front. There are so many policies that are emerging. I mean, in California this year alone, there's over 100 legislative pieces of legislation that are touching substance use disorders. They're impossible to keep track of, and yet they're critically important. So how do we use gap analysis and strategic review to determine what policies we actually need to use, and how do we leverage effective policy to address the social determinants, homelessness, child welfare involvement, employment, and we can go on, that are so critical to stemming various aspects of this crisis. I could go on, but I want to leave room for my other panelists, so I'll stop there for now. Thank you.
My name is Julie Donahue. Like Caleb, I'm also a pointy-headed academic. You can tell because I brought my laptop to the front. But I'm also a family member, and in the spirit of openness and beating back stigma, I wanted to share that my work in this area is very much informed by having lost my first husband to the ravages of alcohol addiction 7 years ago, also the father of my 2 girls. So in that spirit, and I'll try to hold back tears, I really want to commend the work of this group for both the scope and the novelty. I came here thinking that I might hear a lot of overlap between the work of this group and existing efforts, and I couldn't keep track of the number of new ideas I heard this morning. So thank you for that. So I was given latitude by one of our co-chairs, this group is really cross-cutting, so I'd like to share 5 cross-cutting comments or questions. Hopefully it's not coming across as too rambling. So one is, I think we're at an unprecedented time with big data efforts and data integration to support research and analysis on this topic. And I think there's a greater willingness, particularly at the state level, to knock down data silos. At a minimum, we should be linking all payer claims data sets, EHR data, prescription drug monitoring program data, and vital statistics. I know there are still barriers to doing that, but I wanted to call this group's attention to a report produced by RAND for ASPE last year that I found particularly helpful, entitled Data Sources and Data Linking Strategies to Support Research to Address the Opioid Crisis. I think it's a bit of a roadmap for this group's effort. Second, I was really glad to see a major emphasis, particularly in the prevention, treatment, and recovery group, on transitions and linkages with social services providers, as Itai mentioned, that is so important for the population suffering from addiction. And I think there is, again, an increased emphasis and perhaps a new discovery on the part of healthcare payers and social determinants of health. Lots of investments being made, and again, particularly on the data integration and evidence generation side, that this group can hopefully highlight and share. And here I might be diverging a little bit from the sort of data and metrics purview of this particular group. I just wanted to share my own ambivalence regarding value-based payment for addiction treatment at this particular moment in time. I see the tremendous value in marching down this path quickly to improve the quality of care that is so deficient. But I also worry about what happens if we move too quickly and get ahead of performance measurement and outcomes measurement, and also get ahead of a system that is adequately financed under the guise of value-based payment to save money, which often happens, particularly in the behavioral health space, has been argued many times before. As was mentioned in that fourth comment is mentioned in the opening comments, this is absolutely a multi-sectoral problem, but I think we can probably all agree it won't be solved without major leadership from state and local governments. And I think that all of the working groups are in the process, will be identifying barriers to evidence-based prevention and treatment strategies, both for pain and addiction. Many of these barriers will map on quite neatly to policies at the state and local level. And as Itai mentioned, it's incredibly difficult to track, let alone evaluate, the volume of laws being passed by state legislatures. But I guess I would throw out a challenge to this group to go even further than tracking legislation. We need to track the implementation of legislation, of regulations. It's not enough to know what state licensing boards require. we have to find out how those licensing requirements are being monitored and evaluated and enforced. It's not enough to know that a particular Medicaid program requires prior authorization. What are the details of implementation around that policy? So kind of a parallel comment to Itai's comment about implementation on the health system side. And finally, the working groups are proposing to generate some really important resources for the public, for practitioners, payers, policymakers. And it has been mentioned previously, I just want to underscore the importance of thinking expansively about outreach and implementation and dissemination. And I just wanted to sort of call out one of the working groups that promises to sort of harness the power of social networks and professional networks. I think it was the treatment prevention and recovery work group. Laid out a really thoughtful outline of an ecosystem assessment that I thought would be worthwhile sharing with all of the work groups. So that's all I have. We'll let Richard have the last word. Thank you.
Thank you for another really terrific panel. You know, the motto of the National Academy of Medicine takes its roots in Goethe's quote that knowing is not enough, we must do. And this panel certainly followed that, but also added on that we must do, measure, and be accountable. So please join me in thanking Kelly and Carlos, Itai, and Joy.